Hello, welcome to this ARCP preparation, specially recorded session. Today we are going to be talking about urology and the preparation for ARCP and relating to the new 2021 curriculum, and I'm delighted to be joined by Dominic Hodgson, the Urology SAC curriculum lead. Morning, Dominic. Thank you very much for making the time. We're going to start with a summary from your urology perspective about the curriculum and the changes, put it into context, and then I will have some questions to ask specifically that relate to the critical progression points, the critical conditions, index procedures, and pulling that all together about how to get the optimum outcomes from ARCPs. But first, over to you, Dominic.
Thank you, Keith. So, in keeping with all hospital specialties, urology introduced a new curriculum in August 2021. This was in response to the GMC's concern that the previous curricula hadn't emphasised sufficiently behavioural aspects, and as a result, consultants were subsequently failing in these aspects of their practice. Over the next few minutes, I want to explain how the curriculum can be best used to your advantage by describing the generic and then specific qualities that need to be developed and how these are assessed. So, the GMC recognised that there are core skills required for effective working common to all doctors, such as those around patient safety and professional values. These are described as 9 generic professional capabilities, or GPCs, and are assessed to highlight areas of good practice, but also identify areas that need to be developed. These are considered by consultants during a placement who meet to discuss the trainee and generate a report, the Multiple Consultant Report, or MCR. These meetings occur twice in a placement, the first at the midpoint to review performance, and the second towards the end of a placement to be used as evidence at the ARCP. The second task of the MCR meeting is to consider specialty-specific competencies known as capabilities in practice, or SIPs. In urology, these are grouped around working in theatre, outpatients, emergency, multiple disciplinary teams, and inpatients to assess not just technical abilities, but the whole process of patient care. Key to this assessment is consideration of how much supervision the trainee requires to perform, graded from level 1, where the trainee is just observing, to level 5, where the trainee is performing beyond the level expected of a newly qualified consultant. To progress from phase 2 to 3 of training, I'm going to talk more about that later, it is necessary for trainees to reach supervision level 3 in the MCR, and key to this will be managing critical conditions, for example, high pressure chronic retention or renal trauma, and performing index procedures such as TURP and ureteroscopy, and for CCT to be appropriate for phase in all GPCs and reach supervision level 4 in the SIPs. The SIP supervision levels that it is hoped that the trainee will reach during their placement are set in an initial learning agreement, taking into account comments from the previous ARCP, the previous MCR, and the trainee's self-assessment. There are 3 phases to training. The first, prior to national selection, where the MRCS is obtained, and this will include a year of urology. The second, as ST3, 4 and 5, when core urology should be experienced in preparation for the FRCS urol exam. And the final 2 years, when the trainee should spend time pursuing a specialist interest in female and functional urology, endourology, oncology, andrology, or advanced general urology.
Thank you, Dominic. That's very clear. I'm going to ask some specific questions now, just to highlight some aspects. So about critical progression points, those marked at the end of phase 2 and phase 3. Could I ask you to define what those mean and the levels that were applied within urology?
So I think an easy way of thinking about the progression from phase 2 to 3 is when the trainee should be ready to sit their exam. So that means that they wouldn't necessarily have all the technical skills of a consultant in terms of operative skills, but they should be able to manage the critical conditions, and that would have been demonstrated through CBDs and KEXs. And they should also be in track on other aspects of the GPCs towards final CCT. The CCT, they should have achieved the whole of the curriculum, and therefore demonstrated that they are able to perform at a level expected of a new consultant through KEXs, CBDs, and PBAs in the critical conditions and index procedures.
Thank you. So to go back to summarise that from my perspective, it seems that the outcome of phase 2 relates to knowledge, clinical and professional skills, and therefore the management of the unselected emergency take in general or core urology to the level of a day 1 consultant. And that's the level you'd expect a trainee to acquire in order to get an outcome 1 ARCP, and that would be the necessary sign off for them to take the exam. Whereas phase 3 is the maintenance of those skills in core urology and the development of technical skills to the level of a day 1 consultant, and the development of the specialty interest module. And hopefully I'm correct in that, therefore, the CIP supervision levels at the end of phase 2 for urology are 3, and at the end of phase 4, as you expect, are 4 or 5, 4 being to the level of a day 1 consultant and 5 being showing excellence above the level of a day 1 consultant. Can I ask about the exposure to special interest? Can that occur in phase 2, and that you do in phase 2 will continue to be recognised for phase 3? Is that correct?
That's correct. So inevitably, you know, there's going to be some exposure to urology beyond that of core urology, and of course that could count as subsequent special interest model going forward.
Thank you. What might happen if a trainee at the end of phase 2 had not been able to show the required levels, be it within the index procedures, critical conditions, or as assessed within the multiple consultant report?
So if that hadn't been achieved, there would be 2 options. Either they could progress to the phase 3 of training but not be considered suitable for sitting the exam. So
that would be an ARCP outcome 2.
Outcome 2, correct. So there would be no need for further training at phase 2, but there would be areas that would be highlighted that need attention, and when they were achieved, then they could then sit the exam, or it would be thought during the ARCP that they had sufficient deficiencies that further training would be required, and that would be an outcome 3.
Thank you. So you mentioned the critical conditions and the requirements related to KEX and CBDs as the form of assessment of those, which segues nicely in to me being able to ask a little more about these. My understanding that within urology there are 14 critical conditions. Can I ask you what they represent, maybe to define those, and what opportunities do you see the trainees having gaining experience and expertise that's necessary for a favourable MCR and ARCP outcome?
So I'd refer those watching to Appendix 3 in the curriculum. So that's on page 72. So the critical conditions are listed there: renal trauma, iatrogenic bladder injury, iatrogenic ureteric injury, septic or shock patient, high pressure chronic retention, penile emergencies, acute scrotum, ureteric obstruction, penile fracture, Fournier's gangrene, TURP syndrome, post-TURP bleeding, spinal cord compression, and the acute abdomen. So for completion of phase 2, they should have competency levels demonstrated at level 3 for all of those, and of course for level 4 for phase 3 at level 4, and those would be demonstrated by CBDs and KEXs. So you can see that all of those are pretty much, perhaps with the exception of post-TURP issues, around the emergency take. So that would be very much the focus for the especially the phase 2, the core urology experience, when it would be hoped that there'd be exposure to those.
So just for clarity, since it's very clear the level required, so for on the whole phase 2, the level is indicative of an outcome 3 for a CBD or KEX, whereas for phase 3, as expected, it would be level 4, appropriate for certification. So, but how many of each of it requires? Is it, as my understanding, that it is one assessment for each of those critical conditions at that level?
That's correct. Yeah. So they would have demonstrated suitable for the level of training at the end of phase 2, and for being able to independently manage as assessed by CBD or KEX at CCT.
Excellent, thank you. So the next question I was going to ask related to the index procedures, those that are in Appendix 4 of the curriculum. Can I ask you to define what those index procedures are, and overall what opportunities the trainee will have in gaining the appropriate experience and expertise that's necessary in these?
So these are index procedures that we think are absolutely essential to be able to perform as a urologist, and the purpose of them, one of the purposes of them, is to try and focus training around them, so appropriate for the stage. So the index procedures for all trainees are urodynamics, prostate biopsy, a lower urinary tract symptom procedures such as including TURP, TURBT, penile scrotal procedures including orthopexy for torsion, and ureteroscopy and lasering of stone. So for phase 2, there should be PBAs to a level 3 for everything apart from urodynamics, and there should be at least 4 PBAs for each of those. So 4 PBAs by at least 2 assessors. And then for phase 3, they should all be have PBAs demonstrated at level 4, and we would request 9 of those by at least 3 assessors to really demonstrate that these levels of competencies have been achieved. And then in addition to that, for the special interest modules, female and functional endourology, oncology and andrology, there are further procedures that need to be performed at level 4 as assessed by PBAs for CCT.
Thank you. And so there are, for those special interests, a trainee would need 4 of each of the PBAs within their special interest. So they'd only do one special interest module. Is that right?
Yeah, I mean, I suspect there would be scope to do more than one, but yes, they would need to. So specifically for female, it's autologous sling, endourology, flexible ureteroscopy, oncology, laparoscopic nephrectomy, or radical cystectomy, and ileal conduit. Andrology, a simple Nesbit's procedure, and advanced general urology, an additional bladder outlet obstruction operation.
Okay, that's very clear. And can I just ask, at the end of those respective phases, and thinking about those index procedures, overall, what would the logbook look like? Is there any indicative logbook numbers associated?
So I think one fear with the new curriculum was about what would happen to the logbook, but it's emphasised in the curriculum that it's very important that trainees still keep a logbook. So we want to know all aspects of the procedures that are being performed, but those index procedures are ones where we think there's of sufficient importance that we want specific PBAs at those levels for those, rather than the previous indicative numbers from the old curriculum, because remember, this new curriculum is all about competencies, not just numbers.
Excellent. So my final question really relates around the evidence a trainee may need to provide to get an outcome 1 ARCP at the end of phase 2 and at phase 3, and within that, really, the understanding of what the difference is between the demonstration of competence and excellence within urology.
Okay, so competency is assessed through the CXs, the CBDs, and the PBAs. So competencies for the end of phase 2 training would be to have been demonstrated competencies in the index procedures and the critical conditions. An assessment of excellence is made through the MCR. So it can be commented in the work-based assessments that the training is performed excellently, but specifically level 5, i.e. beyond that of a day 1 consultant, is an assessment that's made during the MCR.
And that's within the CIPs.
Within the CIPs, correct.
Excellent. And I suppose, whilst you wouldn't necessarily be expecting, therefore, a trainee to be getting CIP outcome 5 at the level of the end of phase 3, but excellence at that point may be represented by them already being at phase 4, or sorry, at level 4 supervision level as an assessment, or maybe those trainees that achieve the supervision level 3 quicker than the indicative time.
Yeah, correct. I mean, as we've said before, this is a competency-based curriculum, so people may achieve at different speeds.
And for the finish of phase 3, the ARCP 6, there are very clear certification requirements. Then, in addition, up until that point, the training would have been appropriate for phase within the GPCs, but there are, in addition to the critical conditions and the index cases and the MCR, or essentially within, there are those aspects of research, management, and teaching, which are certification requirements.
Correct. So one thing to emphasise is that obviously they will have passed both parts of the FRCSC role, and they will have achieved an ARCP outcome 6, unless they're going through the CSER route, and then they will demonstrate equivalence. So yes, so this means demonstrated abilities in research, quality improvement, medical education, management, and leadership. And probably with regard to research, the best way to demonstrate that is through publication.
Yeah, although that we do, as the JCST along with COPS do provide now some generic research guidance in relation to research requirements for the trainees. That will be available on the ISCP, and also will be provided by COPs that represent all the heads of school. Okay, well, thank you very much, Dominic. Well, I think we've gone through that and provide some clear guidance for the trainees to what is required for their ARCPs coming this summer as a change, as the first time that they'll have been assessed against the 2021 curriculum.
Thank you very much.
Cheers.